I'm Cindy Owen. I'm the Director for Clinical Insights and Development for GE Healthcare at Point of Care Ultrasound. I want to talk to you today about lung ultrasound. This is part one of a two-part series, and in this first part we're really going to focus on B-lines. You know, we have two key tools that are related to the lung on Venue. The first one is the Auto B-lines tool, and here it's answering the key question, you know, is there fluid in the lungs where it doesn't belong? And we have an automation, which is the Auto B-lines. So we'll talk a little bit about that and what B-lines are and parameters that affect the quality of the B-lines and how the tool works. And then we have the lung review, which is a very popular tool because it allows the physician to actually look at the exam that they have done and even exams that they've done over a period of time and see the differences in the lung condition between exams. So it's a great way for them to keep track. And the promise is if you survey the lungs, Venue can display a summary. In developing Venue, we literally read hundreds of articles and talked to hundreds of physicians actually around the globe. So what I'm recommending to you here is that you dig into these articles. You have a list of some of the key articles that we studied available to you. And here I've just listed some of the most pertinent ones for B-lines. And I would really recommend that you read these and understand, because the more of the literature that you take the time to review, the more deep your understanding will be. So here's a list of some of the things that I want to talk with you about today. We want to understand the lung ultrasound literature a little bit, so I just spoke to that. I wanted to introduce, if you haven't heard of him already, Dr. Lichtenstein, who is the father of the Blue protocol. This is a common protocol that's used to evaluate the lungs with ultrasound, and you will hear about it. Then let's get into the basics of the B-lines. I want to give you a definition for B-lines so you understand exactly what they are and what they're not. We'll talk about the scan settings that actually affect the B-lines. If we don't use the appropriate scan setup parameters, then we won't see the B-lines the way we expect to see them, and we won't get good results. We'll talk a little bit about patient positioning, how B-lines are counted. You'd think you could just count 1, 2, 3, 4, but actually B-lines are a little more complicated than that because sometimes they merge together. And so we'll talk about how we manage that. And then there's actually different methods of scanning, and I want you to understand why and what those methods are. So let's talk about some of the ultrasound signatures, and let's begin with A-lines. What are the definitions of A-lines? They're a sign of the normal lung in some instances. The A-lines are actually reverberation artifacts. The sound reverberates between the ultrasound crystal and the pleura, which is at right angles to the crystal, so it makes a very strong reflector. And so you get this sound bouncing back and forth, which results in these equidistant horizontal artifacts that fade with increasing depth. So that's what an A-line is. A-lines and B-lines don't really coexist, and we'll talk about B-lines more and their definition in the next slide. So what is the definition of B-lines? B-lines are described very clearly in this article that you can see on the right-hand side. This is an international consensus article that was written by many of the physicians that we've actually worked with or spoken to in the development of Venue. You should familiarize yourself with the names in this paper, and if you don't read very many of the papers that I've listed, this is one that I would highly recommend. It actually defines B-lines in this paper. B-lines are a discrete, laser-like, vertical, hyperechoic reverberation artifact. Wow, that's a lot of words, but basically they're a long white streak in the image. They begin at the pleura, and they extend all the way to the bottom of the image without fading. Now that's very important because there's other lines that are vertical that you'll see in the lung, and they don't go to the bottom of the image. And you want to differentiate B-lines from those lines, which are called Z-lines, and we'll talk about those in a moment. Another important thing to keep in mind about the B-lines is that they move in sync with the lung sliding. We know that the two pleura move against each other when we breathe. There's some lubricant in between them, and that's called lung sliding, and we can actually see that in real time. And the B-lines track that, so that's one way to make sure that you're looking at B-lines. And in general, B-lines erase or at least are written over A-lines. Now, we usually use the term B-lines, and sometimes they're even abbreviated as BLA, B-lines. But there's other words that you'll hear some physicians use, and they mean the same thing. Lung comets, comet tails, and even lung rockets have been used in some of the older literature. So if you look at this image, you see two white streaks in the lung. Are these B-lines? Think about the definition for a moment and make your decision. If you said yes, then you're correct. These are actually B-lines. This isn't in real time, so you're not seeing that they're moving with the pleura, but they did, and they are beginning at the pleura and persisting all the way to the bottom of the image. Now, here's another example, and in this case, I want you to look at the image. Is this a B-line? Remember the definition. The B-lines in general erase A-lines. And in this example, I continue to see the A-lines, and I see this bright streak that's coming down from the pleura in the middle of the image. This is just perpendicular incidence. When we have perpendicular incidence of the sound beam with a tissue, it tends to create a brighter reflection, and that reflection is just extending down to the image. This did not move with the pleura. It did not move with breathing. It doesn't erase the A-lines. This is just bright echoes due to perpendicular incidence, so it is not a B-line. What about this image? Here's another bright streak. It's beginning at the pleura, but it doesn't extend to the bottom of the image. It just goes part way down. This is a Z-line. These are important to differentiate from B-lines, and this is the reason that we keep the depth at least 12 centimeters deep before we'll turn on the auto B-line tool to count the B-lines, because we don't want the tool to count Z-lines as a B-lines, since Z-lines don't have any pathology associated with them. So that's one reason why it's recommended in the consensus paper that I just referred to that we have a depth of at least 12 to 15 centimeters when we're looking at B-lines. Now that's really talking about adults, and of course as we move into children, pediatrics, then we will probably have to change that depth requirement. But at least in adults, we want the depth to be at least 12 centimeters. Now, what parameters affect B-lines? You'll hear me talk in just a few moments while I'm scanning an actual patient with B-lines and give you some examples of these parameters, turning them on and off and how they affect the B-lines. The preset is very, very important with B-lines. Remember, they're an artifact. And in general, with ultrasound, in the past, we've tried to mostly reduce the imaging or eliminate artifacts from the image. But with B-lines, we actually want to preserve the artifact. So some of the tools that we've used in the past to help clean up artifacts from our image actually are deleterious to examining B-lines. These are things such as compounding, persistence, which is another term for frame averaging, having too much gain because it increases all of the brightness around the B-lines and makes it more difficult to differentiate them from the surrounding noise. The frequency is very important, whether it's too high or too low. Dynamic range. If we make the image very gray, it's hard to distinguish the B-lines. And even line density. If the line density is too low, we may count 2 B-lines that are close together as one, so it could really affect our counting. Another thing that's very important is that the focus position, which you'll see here pointed to by a red arrow, should be at about the level of the pleura. Now, when we set our preset, which I said we did very carefully on Venue to preserve these artifacts and make them more apparent and easy to see for the physicians, we did set the focus position where it's close to the pleura for most adult patients. But you may need sometimes to move it a little more superficial, or maybe infrequently one a little bit deeper down. But you'll see in a few moments the example of what happens if you moved the focus all the way to the bottom of the image or even close to the bottom of the image. You lose the beam coherence in the near field and you won't really appreciate the B-lines as a single streak. So it's really important. Other things like harmonic imaging. Perhaps in the future we may see that we can use harmonic imaging for B-lines, but all of the literature right now is discouraging us from using that feature. And it does make it sometimes more difficult to see. So I think the jury's still out on whether or not we can ever use harmonics for B-lines, but perhaps in the future, certainly not right now. And the transducer type really affects the way we look at B-lines. Remember, the beam is formed differently from a phased array to a curved array to a linear array transducer, and they all have their advantages and disadvantages. One of the advantages, for example, of using a phased array transducer is that you can quickly go from the heart to the lungs to the abdomen without ever switching a transducer. You may want to do that when you are an emergency room physician and you have got a patient who's crashing in front of you and you need some fast answers. You don't want to even take the time to change the probe. But in less emergent situations, many physicians will change the probe from the phase after looking at the heart and go to the curved array to look at the lungs. Why? Because they get a better look at the pleura, and they can see the bat sign better, which we'll talk about a little bit more later. And they can really appreciate the B-lines better than they can with the phased array probe. What about a linear array probe? Why do some physicians want to use a linear array? Most of the time when they use a linear array probe, it's because they're really focusing on the pleura itself. The pleura is more superficial. In some cases, especially in critical care, they're very interested in small subpleural or juxtapleural consolidations and surface irregularities, like in lung fibrosis or in patients with ARDS. So in those cases, a linear array can really be helpful. And you just won't see those kinds of small irregularities with a phased array. So knowing the types of transducers and the advantages and disadvantages of each can really be helpful. There's an article here on the right-hand side that's not in the list of articles that was provided to you earlier because it's a little bit newer. But it's very helpful and talks about the parameters that are recommended for B-lines and all the parameters that can affect B-lines, as well as the transducer types. So it's another article that I highly recommend to you. Okay, take a look at this image. How many B-lines do you see in this image? Maybe you said 3. Maybe you said 1. Actually, it is just 1 B-line. Why are we seeing an image like this? This is because compounding is on. Now, if you recall what compounding is, it's actually the beam being steered in multiple directions and then merged together to create one displayed image. This is great in B mode because it gives us closer to specular reflection for different boundaries and enables us to see the edges of all kinds of tumors or organs. It's a great tool, but it doesn't work for B-lines because, as you can see, we can't count B-lines if we have compounding on. I'm really surprised when I Google B-lines and I look at the images on the internet, how many of them actually have compounding on, some even with some of our prior equipment. So be sure that you don't turn compounding on. It's off by default in the lung preset. Okay, let's talk about the quality indicator. You'll see in a few moments, I'm going to scan and you can see how the quality indicator works in real time. And I'll show it changing from green to yellow and to red and back and forth depending upon different things that I do to the image. But this quality indicator is a very powerful message to the physician who's doing the scanning about how much trust they should really put in the results. If the quality indicator is green, then the results they're getting should be equal to those of an expert user. If the quality indicator is yellow, as you see in this right example, then it's telling the user that they should use those results with their medical judgment. In this case, it looks like good results, but you should still take them with a little bit of caution. But when the quality indicator is red, we actually won't show any B-line count at all with the Auto B-line tool because we know that it just can't be trusted. So there's no results shown, and it's indicating to the physician that they should not try to use it. They need to get a better image. Now, how does the quality indicator know this? It looks at multiple parameters. Some of those are probe motion and background noise. And again, you'll see in just a few moments while I demonstrate this. Okay, let's talk about how to count B-lines. And as we start to think about counting them, we need to know what's normal. So what is considered a normal amount of B-lines? Or is there any normal amount of B-lines? Well, the answer is yes. 1 or 2 B-lines within a rib space are considered within normal limits. Keep in mind that as you have a subject who's lying supine over a period of time, all of the fluid that's normally in the lung starts to accumulate in the dependent portions. But greater than 3 B-lines is considered to be a positive finding. Now let me clarify that because I mean greater than 3 B-lines within one zone segment. Okay, so within 1 2-centimeter segment, because that's again about the length of the space between 2 ribs. Now sometimes B-lines will actually fuse together. If we get enough extravascular lung water, in other words, if fluid is starting to accumulate in the lungs, we'll start seeing them fuse together and get wider and wider. So we have to count them appropriately. A single B-line is about 2 millimeters or less in width, just below the pleura. With the increasing extravascular lung water, B-lines begin to merge together. Once they start merging, then we refer to them as confluent B-lines or coalesced or fused B-lines. You'll see several different terms used in the literature. But confluent B-lines are wider than 2 millimeters. And they're counted according to the percent of rib space they occupy. Now again, the typical rib space in an adult is about 2 centimeters. So for example, what we do on Venue and what has been done in some of the literature is that confluent B-lines, say for example, that are 1 centimeter wide, are counted as 5 B-lines because they're taking up about half of the rib space. Now when Venue counts the B-lines, it never counts greater than 5 because 5 is considered to be clinically significant. So Venue will say that it's greater or equal to 5. Now if you look on the right hand side, you'll see a couple of different indicators. On the far right, you see a single B-line, and that's indicated by 1 solid line streak. On the left-hand side, you'll see that there are 2 lines on either side of a white area, and they're joined together at the top, kind of like an upside-down cup or glass. And this is indicating the width of confluent or fused B-lines. So in this case, we're not looking at 2 B-lines, rather we're looking at greater than 5 B-lines. Now, as the patient's condition gets worse, we'll start to see these merged B-lines actually take up the whole rib space, and in fact the whole lung takes on a white appearance. And this can be a little bit tricky because it may be hard to determine whether this is really B-lines or is this just having the gain up too high. But you can clearly see when you have the rib shadows on either side that this area in between is completely white compared to those shadows. And this is a complete white lung. So that's how it's referred to often in the literature, is white lung. And what it means is that there's so much extravascular lung water or pulmonary edema within the lungs that it's just completely filled the space, and it's like one solid huge B-line. But the way we count that is it's actually many B-lines that have become fused together, and it's counted as greater than 5. Now, you've probably noticed on Venue that we actually will give a lung ultrasound score based on a survey of the lung. So what is the lung ultrasound score? This was a score that it was developed, and it's been published in the literature. And it's been developed to really evaluate the overall aeration of the lung. The range is from 0 to 32. Now there's 4 ultrasound aeration patterns that are used. One is normal, which means we have lung sliding with A lines and no more than 2 isolated B lines. 2 is a moderate loss of aeration, meaning that we have multiple well-defined B lines, but they're not fused together. They're not coalesced or merged in any way. 3 is a severe loss with multiple coalescent B lines, and 4 is lung consolidation, because it has a tissue pattern in the lung and is characterized by air bronchograms. And you can see on the right-hand side a table that shows you how the score lines up and gives you a nice explanation of each score. Now there's multiple segmentation models that are used, and it really just depends on the preference at the particular site. Some use a 6x2 segmentation model. This is available on Venue. The Blue protocol calls for a 3x2 segmentation model. Common in the ED is a 4x2 segmentation model, as you see on the right-hand side here. And then in emergent cases, oftentimes in the emergency department, they'll quickly just look at 2 anterior zones, 1 on each side. We don't really have a segmentation model that shows that, but that's just common in emergent cases to quickly rule out pneumothorax and to see if there's B-lines present. And then in Italy, there was a 28 region, a very thorough lung aeration study that's frequently done. Okay, so we've already talked about the definition of B-lines, and we've talked about some of the other lines that you might see, A-lines and Z-lines. Now let's talk about the presets for B-lines. It's so important. As I mentioned before, we need to understand that the settings are appropriate to show B-lines. Some of the settings that we're used to in regular ultrasound scanning can actually interfere with our ability to see the B-lines properly and actually count them accurately. So let's take a look. I'm going to scan across his ribs, and I'm going to change some of the parameters so that you can actually see a cause and effect of what happens while I'm scanning in real time with the B-lines. Okay, so the first thing I want to do is just orient the probe on the body so that I can see the bat sign. And the bat sign is really related to the 2 ribs creating a shadow, and then we see the pleura behind that, and we can actually see B-lines coming in and out. So we're looking at the zone of the lung in between those two shadows, which are the ribs. Now you can see the B-lines going back and forth, and as I described before, they're really discrete laser-like lines that start at the pleura. They go all the way down to the bottom of the image. Remember, if it doesn't go all the way down to the bottom of the image, that means it could be a Z-line instead. Okay, so we would count the B-lines that go all the way to the bottom. But what we want to do is stick with our lung preset, because if we started making changes, we might lose our ability to see these B-lines well. For example, one of the things I told you is really important is having the focal position up near the pleura. And you can see the focal position is pointed right up here, very close to where the pleura is. But look what happens if I put the focus all the way down towards the bottom of the image. I don't see the B-lines near as clearly now. Let's take it back up. Look at the difference in having the focus up near the pleura. And I'm going to take it back down. And with each step that I take it down, you see less and less of the B-lines. Okay, so if your inclination is, like many sonographers, to take the focus down low, keep in mind that you're actually going to lose the ability to see those B-lines. So now that we've got it set in a more appropriate setting, let's look at some of the other parameters and their effect on B-lines. What about compounding? Now, we might want to have compounding on if we're looking at a lung consolidation, because that's going to help us see all of the borders and the boundaries of that lung consolidation. On the other hand, if we turn it on when we're looking at B-lines, look what happens. I'm going to actually increase my gain here just a little bit. But you can see now, it's really hard for me to count those B-lines. Instead of just a discrete laser-like line, they're spread out in a single B-line. Looks like it's actually maybe 3 or 4 B-lines. So I'm going to turn that back off. Okay, so we've got the probe over a nice image showing the bat sign with the 2 shadows. And what I want to show now is the effect of the gain. One of the things we want to do is maybe have a little bit of noise in the background like you see, but we don't want to have a lot of too much gain so that we get a lot of noise. Because once there's a lot of noise, it becomes more and more difficult to discriminate the B-lines versus the surrounding noise floor. So look what happens. As I increase the gain, it gets harder and harder for me to differentiate the true B-lines from the surrounding noise floor. Now, believe me, I've seen a lot of images that look quite a bit like this when I peruse the literature sometimes, or even if I just Google B-lines. But honestly, it's really quite difficult for us to determine whether this is truly B-lines or is this white lung. And if I turn on the Auto B-lines tool, you can see that the quality indicator is yellow, and we'll talk about that just a little bit more later on, but that quality indicator is telling me how much confidence I should actually have in the B-lines count. You'll notice that as I turn the gain back down to a more appropriate level, now the quality indicator turns to a green, because the algorithm itself is better able to discriminate the B-lines from the surrounding noise floor. So gain settings are very important. Bottom line, have just enough gain that you have a little bit of noise perhaps in the far field, but not so much gain that noise is filling everywhere else and it becomes difficult to discriminate the B-lines from, say, a white lung. Okay, the next control I want to talk about is frame averaging and the effect that it has on visibility of the B-lines. The B-lines move with the pleura, right? That's part of the definition of the B-lines. So we really want to appreciate that, and that's one of the ways that we differentiate it from other artifacts that may be present. So the typical preset has the frame averaging all the way turned off so that we can really appreciate the movement. Look what happens to the image if I turn that on, the frame averaging all the way up. It really, again, kind of like the compounding effect, it smears the B-lines and makes it a little bit more difficult to see, and we lose that real-time nature of the motion of the B-lines and the sliding of the pleura, which we really want to appreciate. So it's important to keep the frame averaging down so that you can see the B-lines move in real time. We thought long and hard about these presets, and we wanted to make sure that we get it right. All right, so now I want to talk about the effect of probe on the visibility of B-lines. Right now we have the B-lines auto tool working with the phased array and the curved array, and these are our typical probes that are used for B-lines, but all probes are not equal when we come to assessing B-lines. The curved array has advantages in that it shows the pleura very nicely, and it also shows a wide field of view. The phased array has an advantage of really getting in between the ribs nicely, but it doesn't show the bat sign very well, and it doesn't really show the pleura very well, but it will show the extension of the B-lines to the far field. The linear array, on the other hand, shows the pleura beautifully. So if you're really looking for consolidations, especially small consolidations, the linear is the way to go. Any kind of pleural irregularity, it's going to show better than the phased array for sure. And it will also beat out the curved array in that regard. But the problem with the linear array is that penetration, of course. It's not going to penetrate quite as far. And we've talked a little bit about the reason penetration is important. And just as a reminder, that's because it helps us to differentiate B-lines from other artifacts, such as Z-lines. Z-lines don't extend all the way down to the bottom of the image, and they aren't a sign of pathology as B-lines are. So what I'm going to do is just scan with each of these probes so that you can see in real time the difference between those. I'll start with the curve because that's what we've been using. And here what I want you to appreciate is that you can see the pleura move back and forth really nicely. You can catch a little bit whether or not there's some irregularities with the pleura. You can see the B-lines extending all the way down to the bottom of the image. And with the wide field of view, you can also get a good feel for the bat sign, which is really nice. Now I'm going to switch to the phased array probe. With the phased array probe right away, you can see that it's harder to see the bat sign, isn't it? It's also harder to see the pleura clearly. Now I can make it out right there at the top because I can see it moving back and forth. And I can see the A lines. And I'm actually going to increase my gain just a little bit to help me bring in those B lines. So there's the B lines. But you know, they're just a little bit more difficult to see than they are with the curved array probe. So you can see right away that there's, although a lot of times the physicians will want to use the phased array probe because they can then use one probe that goes from the heart to the abdomen to the lung. It's not quite as good for looking at the B-lines and the pleura and the bat sign as, say, the curved array probe. Now what about the linear array probe? The linear array probe is really, in one sense, the very best probe because, whoops, let me just select it here. In one sense, it's the best probe because, you know, the beam is fired straight down, and so you can really appreciate the pleura very clearly. You can really appreciate the B-lines very, very clearly. But it doesn't give us great penetration, and for that reason, it's not the standard probe because we want to be able to penetrate to a deeper depth and clearly discriminate those B-lines from the Z-lines. But you can notice the pleura much better. You still can see in this particular patient the bat sign fairly clearly, and that you can see the pleural irregularities that are present. That you couldn't appreciate really at all with the phased array probe. Now when you talk to emergency and critical care physicians, you will hear different opinions about which probes they want to use, and it's really based on personal preference, but there is literature that shows the difference in counting between the B-lines between different probes and the different advantages and different disadvantages of the various types of probes. And I encourage you to read the literature. I've given you examples of the literature, and the more you read that and understand it, the better you will be able to talk to this when needed. Okay, now we're going to talk about two different methods of scanning the lung for B-lines. One is called the across the ribs method, and that's the most common by far. This is where you've heard me refer to the bat sign, and this was really initiated by Dr. Lichtenstein. The bat sign represents the two ribs, and then you see the lung with the pleura in between them. But there are some physicians, especially in ICU and critical care, who prefer to scan along the ribs. And what I mean by that is that then they're not showing the ribs at all, they're just showing a long image of the pleura. In general, you'll find that there's these two different camps with two different views of point of views on this, and they're not going to sway to the other side. So the standard in the emergency department is really the across the ribs approach with the bat sign. But in some ICUs and critical care units, you'll find groups of CCU physicians who will prefer to scan along the ribs. And the reason for that is because they want to see a longer extension of the pleura. They're really evaluating that, and they want to see as much of the lung as possible as opposed to really just counting within that. So Venue supports both of these scanning methods, but as you can imagine, if we're going along the ribs, we're going to see more lung and we're going to see more B-lines. So we have to have a way of counting the B-lines that compensates for these two different methods. And so what happens is that we're still going to look just within a 2 centimeter section of the lung. 2 centimeters is about the lung width between the two ribs. So when we're going along the lung where we don't see the ribs, we'll just look at 2 centimeters for counting. So let's scan. You'll get a graphic that displays for you whether you're actually across the ribs or along the ribs in your settings. And that's the quality indicator graphic that you can see here. It's a shorter graphic. And this graphic is the default graphic, and it's set to tell you that you are looking across the ribs. And so what the system does is it looks for B-lines within that whole green area, and that's defined by the vertical aspect of both of those bars that's pointing back up to the surface of the screen. Now, if I go into settings and go into the config, I can actually turn off the across the rib setting. I'll exit config, and now what you'll actually see is that the green bar extends all the way across the image, because if I change my orientation from seeing the bat sign now to going along the ribs, look how much more of the lung I can see. I get a lot larger view, but I also see many more B-lines. So again, in order to make this consistent in counting method with the across the ribs technique, what happens is that you'll notice that some of these B-lines are faint dotted lines, whereas others, the graphic that's displayed is a solid white line. And that means that what the system is doing is it's looking at all of the B-lines across this whole screen, but it's only counting the ones within a 2 centimeter spread. So it looks like for the largest amount of B-lines within a 2 centimeter spread. And that 2 centimeters could be anywhere along this axis of this green bar. And then when I freeze, it will actually look at the B-lines and just count 2 centimeters worth of B-lines. And it didn't count this one, even though it documented it, because it's outside that 2 centimeters. So once again, that's two different methods for scanning along the ribs like this, where you see more of the pleura and more of the lung, and then across the ribs where you see the bat sign, and then when you go into config, that will be your default. That's the most common method for scanning in the emergency department, and the other one is more common in critical care and ICU. But there's definitely some overlap there. But in general, what you'll find is that it's done in one department I want to talk a little bit about the quality indicator. The quality indicator is very important because it lets the user know how much they can actually trust the results of their scan. When the quality indicator is green, it's really telling the user that their results should be equal to those of an expert. But the quality indicator is looking at multiple things, and if it turns to yellow, that means that they should take the results with caution. And of course, if the quality indicator is red, then no results are going to be shown by Venue because they just can't be trusted. So what affects the quality indicator? You can see now I have a nice image, and my quality indicator is green. But if I'm moving around a lot, notice how it changes from red to yellow, and it's not green at all. Because every once in a while it can pick up some B-lines, but it just really can't be trusted because there's too much motion. Now that could be the person scanning, it could be the patient who can't be still, either one. But if there's too much motion, that quality indicator is not going to be green. Okay. Another thing that can affect it is if there's just too much noise. If there's too much noise, say maybe the gain is too high, and I showed this a little bit earlier. Notice as I increase it, eventually the system is having trouble differentiating those B-lines from the surrounding noise floor. So is my eye. So in that case, the quality indicator is yellow, saying, okay, if this is the best you can do, here's your results, but you should really think about, how much confidence you have in those results, because the quality indicator is telling you to be cautious. So the quality indicator is right there where you're looking, and that's intentional because we want the user to not have to distract their eye from actually looking at the pathology or anatomy on the screen, and at the same time still know if the quality of their scan is adequate to evaluate the results. One of the favorite tools associated with the lung ultrasound on Venue has to do with the screen of the lung review. And you can see right here I have a little pictogram that helps me as the scanner to actually go through the segments of the lung. And that can be really important and a great time saver because if I start, say, on the right side, it can actually just transition for me to the next lung zone. As soon as I'm happy with an image, I freeze and store, and you'll notice that it just transitioned to the second one. It's saving me a button press. And believe me, this can be very important for our users in the emergency and critical care department because every second counts in some of these patients. So what I'm going to do is just show you what the lung review looks like. I haven't completed a full exam, but if I wanted to check where I was and see what kind of pathology I'd seen, what are the B-line counts in the various lung zones that I've been to thus far, I can clearly see that at one quick glance. And then I can easily just get back to my scanning and continue the exam. And the system remembers exactly where I left off and allows me then to continue my exam onto the next zone. Every time I store, it just pops to the next zone again. Freeze and store. Now, there is, the auto increment is very, very handy, and like I said, it's a time-saving feature. But if you go into settings, there'll be some who will actually want to turn the auto lung zone increment off, and they can tap it manually to go lung zone to zone. Even if you have it on, you can tap it manually to go zone to zone, but if you turn it off, it won't auto-increment. And some prefer that because then they can actually easily take multiple images in one zone and then transition to the next, and they don't get lost. But others really like the time savings of the auto lung increment. And then into the review screen, and here you can see the full review screen that's completely filled. You can take more than one image in a zone. You can, I only have one image as an example right here, but you can actually add a summary. You can review multiple images, delete some of them if you wish. So it's very, very helpful and important view that we have. Okay, there's a couple of different segmentation models for the lung that are available on Venue, and I'm sure we'll be adding more in the future as we learn more and more about the way our users want to evaluate the lung. But you'll notice that the default comes up with a 4-segmentation on each side of the lung with a total of 8 segments. If you go into settings and into config, you will see that there's a lung diagram type, and it says lung 4x2, so that's the default. So it's a total of 8 segments in the lung that are scanned. And then there's also a 6x2 segment, and here you can see the 6x2 segmentation where you have actually 6 on each side of the lung. Now, I've referred several times to Professor Lichtenstein because he is one of the most knowledgeable physicians there is on lung ultrasound, and he was one of the, if not the, one of the pioneers, if not the pioneer of lung ultrasound. So you should know who he is and his impact on looking at the lung with ultrasound. He's written many papers, but he wrote 2 in particular that you will hear about quite frequently. And the most important and most referred to paper is on the Blue protocol. So you've probably heard about that. The Blue protocol, as I mentioned earlier, looks at 3 zones on each side, which you can see in this example down below. And then it uses a decision tree, which looks very complex, but actually isn't very complex, on the right side. And what it does with this decision tree is try to look at patients in respiratory distress, acute respiratory distress, and decide what's the cause of their respiratory distress based on the lung ultrasound. And he does this by looking at what he calls the A profile, the B profile, the AB profile, the B plus profile, a C profile, and an A plus profile. Wow, that all sounds very confusing, but it's really not that complex. If you look at the picture on the top left of the lungs, you can see an A profile. You might guess the A stands for A-lines. So if you have bilateral A-lines, then you have an A profile. B stands, of course, for B-lines. So if you have bilateral B-lines, you have a B profile. And then the AB profile, you guessed it, if you have A-lines on one side and B-lines on the other side, then you have an AB profile. Okay, so those profiles can actually tell you a little bit when put in context with the patient condition and presentation and the presence or absence of lung sliding. They can give you strong clues about what's going on with that patient. For example, if you look at this graph, you'll see lung sliding. On the left-hand side, if lung sliding is present and you have a B profile, that's consistent with pulmonary edema. If lung sliding is present, you have an A profile, then it could be pulmonary edema, pulmonary embolus, it could be pneumonia, it could be COPD or asthma, depending upon perhaps if they have a thrombus in the leg, which you may or may not see, or they may or may not actually have time to look for, and other factors. The C profile is not shown on the top images of the lung, but the C, as you might have guessed, stands for consolidation. So if there's an AB profile or C profile, then you're suspicious for pneumonia. And if there's no lung sliding and you have a lung point, then you're very suspicious for pneumothorax. But the absence of lung sliding in and of itself is not specific for pneumothorax. So that's all I have for today. Remember, I said there will be a next time, and there we'll talk about pneumothorax and pleural effusions and maybe some other lung conditions, because the science is still evolving. We're still learning a lot. It's an exciting field. I'm absolutely thrilled about all of the information that can be gleaned from the lung by ultrasound. It's amazing. So Stay tuned and we'll talk about this some more, and thank you very much for your attention.